Okay, good morning. I wanted to welcome everybody. My name is Dr. Gary Blick. I am the co-founder of World Health Clinicians and also the co-founder of AIDS Project Zimbabwe. Today's session is entitled The Power of Partnership, Zimbabwe's Ministry of Health and Childcare, AIDS Project Zimbabwe, and the work of NGOs that combat HIV infection in Zimbabwe. There's been a lot of work over these last many years that brought us to this point of having this satellite symposium. Yet here we are to talk about partnerships that help to bring services to communities, partnerships and joint efforts like those developed between the Zimbabwean Ministry of Health and Childcare and an NGOs such as AIDS Project Zimbabwe. I'd like to introduce you to our co-moderator this morning. Dr. Owen Mugarungi couldn't be here, but I'm proud to introduce you to Dr. Charles Sandy, who's Deputy Director of Tuberculosis for the Zimbabwe Ministry of Health and Childcare. Dr. Sandy?
Thanks, Gary, and very good morning to you, colleagues from Zimbabwe, colleagues from other parts of the world. It's going to be a very good session where we are sharing our experiences in terms of partnerships for health. Zimbabwe is a poor country in Africa. We have our government which prioritizes health issues to a large extent, but our efforts as government will not be able to make an impact without the support of partners. I think this partnership with Gary and his team has led to a significant improvement for the services that we offer in Victoria Falls, one of our towns which has a very high burden of HIV. We are going to start off with Dr. Apollo, my colleague in the Department of HIV, AIDS and TB. We have got two deputy directors. One of them responsible for TB, and Dr. Apollo is responsible for HIV and STIs. So she's going to present an aspect of what the ministry's policies and programs have done in terms of antiretroviral therapy from a biomedical perspective. So, Dr. Apollo, I think you have the floor.
It's my pleasure to take the podium and make this brief presentation on health sector responses to the HIV and AIDS epidemic in Zimbabwe, focusing on the antiretroviral therapy program. I would like to acknowledge BAPZ AIDS program, Zimbabwe, for hosting this meeting. Dr. Gary and your team, thank you very much. So I'll present a brief background and then Zimbabwe HIV epidemic, and then I'll zero in on the treatment scale up and some of the issues that we face as a country, a SWOT analysis and moving ahead with the responses. Zimbabwe has a population of about 13 million people, according to the latest census, and HIV remains one of the main public health challenges that cause significant morbidity and mortality in the country. We estimate that about 1.4 million people are living with HIV, and this includes about 156,000 children. Currently, we have about 825,000 people that are receiving antiretroviral therapy, including 57,000 children on treatment. The HIV prevalence has been falling in the last couple of years, from a peak of 28% in 1997 to 15% in 2013. However, there is a disproportionate prevalence between gender, with females having a higher prevalence of HIV. The HIV prevalence decline is mainly attributed to the successes in the country in terms of implementation of the prevention strategies, especially behavior change, high condom use, and reduction in multiple sexual partnerships. The HIV prevalence has sort of plateaued in the last couple of years, and this has really been attributed to improvements in terms of survival of people living with HIV/AIDS receiving treatment. The UNAIDS has reported significant reductions in Zimbabwe in terms of new HIV infections since 2005. There's been 34% reduction in incidence. And also in terms of morbidity, we've seen a 57% reduction in terms of AIDS-related deaths from 2005 to 2013. The decline in HIV mortality is associated with a rapid scale-up of treatment program from 2004 when the program started, with now close to 820,000 people receiving treatment. The health sector responses to HIV and AIDS comprise of a number of interventions from HIV prevention. We have HIV testing and counseling. We have a comprehensive condom program, STI prevention and management. We have the voluntary medical male circumcision program, the EMTCT program that has been highly successful, as well as the antiretroviral therapy. So for the purpose of this presentation, I will focus mainly on ART and related programs. So HTC is one of the important pillars in terms of HIV services, and it's the first 90 of the 90-90-90 global strategy. And there are many approaches that are being used in the country, mainly the provider-initiated testing and counseling, which is widely implemented in many public health facilities. However, we're keen to focus going forward in terms of those high-risk groups based on the hotspots mapping and others, targeting populations that are key and that are likely, that where we're likely to get the greatest yield. We do have good partnerships with different agencies that provide different services to support the national program. However, we have challenges in terms of linkages between those people that are tested and linked to HIV services, including VMMC and treatment and care programs. So that is an area that we need to strengthen. We have some opportunities in terms of piloting some HIV self-testing approaches through the STAR project, which will be launched in the next couple of months. And this is part of a multi-country project that looks at assessing the feasibility and acceptability of HIV self-testing tools in our population. So we hope that we'll be able to increase access to HIV self-testing tools and to inform the market entry in terms of these particular technologies, inform demand, as well as identifying special population and distribution channels that will be used to implement this program. The EMTCT program has been running in the last, since 1999, and it has been evolving over time with only 3 PMTCT pilot sites. And we started off with a single-dose nevirapine, but the program has been evolving to the extent that now we're implementing option B+ in all the health facilities. So we've seen actually a reduction in terms of MTCT rate from about 30% in 2009 to about 7% in 2014. And this is really attributed to the highly successful program in terms of training and decentralization of services and follow-up of these mother-baby pairs. We've got strong partnerships by different agencies in terms of supporting different aspects of our program. However, we experience still late booking of these mothers and some home deliveries that are actually barriers to the success of this program. So this is a recent study which was conducted with support from CDC, looking at the effectiveness of the national PMTCT program. And what we observed was that at 18 months, there was an HIV transmission rate of 7%. The HIV care and treatment program has been rolled out successfully to over 1,400 health facilities in the country, and currently we have a coverage of more than about 65% for adults and about 55% for children. And the success of this program is attributed to the use of standard and simplified treatment guidelines that are implemented at all the health facilities, including public and private sectors, the decentralization of the services, use of standard training curriculum, and mentorship and quality improvement projects that are embedded within the program. We've got effective partnerships as well across the public and private sectors to really implement this program. We also are cognizant of the high levels of TB, HIV co-infection rates at about close to 70%, and hence the need for us to implement TB, HIV collaborative interventions And over time, in the last couple of years, we've actually seen an increase in terms of uptake of testing among TB patients and intensified TB screening among people living with HIV and AIDS. We've seen high levels of increase in utilization of in terms of ART among co-infected patients, and also we're implementing isoniazid preventive therapy, which is given to people living with HIV who do not have TB. We did some study to evaluate trends in terms of TB case notifications since 2000 to 2013, and in relation to ART coverage. And what we found is that the resurgence of TB in the early 2000s was actually correlating with HIV, the advent of HIV in the country. And with the rollout of antiretroviral therapy programs starting from 2004, it actually correlated with the decline in terms of TB notifications across the different forms of TB. So we attribute this decline of TB notifications to the success of the antiretroviral therapy program. We also do evaluate retention outcomes of people living with HIV, and at 12 months, based on electronic patient medical system, which tracks people living with HIV at 83 sites in the country. These are high volume sites, the central and district level hospitals. We realized that about 98% of patients continue on ART at 12 months, retained on the first line regimen, including those patients that have been transferred elsewhere. And in terms of HIV drug resistance surveillance that we conduct, we also realize that the high levels of viral suppression for those patients that are retained on treatment at 12 months. We also do some modeling to estimate the impact of ART and PMTCT programs, and we realize that over 300,000 life years were gained through the provision of ART and PMTCT interventions only in 2013. So we also observed with data from the World Bank that life expectancy improved quite significantly from about 35 years in the mid-2000s to 58 years in 2012. However, we do have challenges in terms of commodity security for antiretroviral therapy medicines. As you see this example from the adults, ARV, we do have some funding gaps that need to be addressed. Even now, as we look into the future, when we have some discussions around test and treat, these are some of the issues that we need to address. In terms of our strengths as our programs, we have strong management, leadership, and coordination of the HIV response, effective partnerships, including our partnership with BAPZ AIDS Project. We do have a rapid decentralized system. We have a well-structured health delivery system, and we also have, in terms of challenges, we have challenges around health workforce, having adequate numbers of health workers to provide services, and even as we do task shifting and all that to ensure that services are provided at lower levels, this is an area that we need to strengthen. We have a relative low pediatric ART coverage compared to adults that needs to be addressed. Financial gaps for medicines, for lab in terms of monitoring patients on treatment, and the EPMS system is being rolled out. We're still using paper-based system in most of our health facilities. We do have opportunities, including the AIDS levy, which we hope that there will be an increase in terms of revenues being collected. We did launch our public-private partnership framework recently, and we hope that this will be an opportunity for us to leverage on resources across the sectors. There are other initiatives that have come on board recently, including the All-In initiative, the Dreams initiative, and also recently, just last week, we were informed by the Global Fund that our incentive funding application was actually approved for Zimbabwe. Threats: dwindling financial resources to fully finance our health response. So looking into the future, we hope to close the gaps towards the 90-90-90 global targets. We're trying to also strengthen adherence and retention of people living with HIV on treatment towards viral load suppression. We continue to scale up viral load testing. We're looking at only about 5% of the total population that is receiving an annual viral load test. We want to get to 90%. We also continue to pursue decentralization and integration of services across the different programs. I would like to acknowledge that many agencies that are working with us towards this noble cause of addressing the HIV challenge in the country.
I think what we can learn from the presentation is that HIV is a major problem for Zimbabwe. The good aspect is that we are dealing with the situation effectively. A lot of progress has been made over the years in terms of scaling up the rollout of ART, scaling up HIV testing, and the results can be seen where we see that the prevalence has come down, people are living longer, but the challenge remains in that we don't have adequate funds to sustain our response. So I think the partners and partnerships that we have will need to be sustained for a long time to come, and will continue to need that support. Moving on now, we have Dr. Tapua Magure. He is the CEO or Chief Executive Officer of our National AIDS Council in Zimbabwe, and is going to talk to us about effective partnerships and the involvement of communities and people living with HIV and AIDS through the stages of planning, implementation, and evaluation in reducing stigma and focusing towards ending AIDS. Dr. Magure, over to you.
Okay, thank you. I just want to rattle through this second zero. As you know, under the 3 zeros, we want to reduce AIDS deaths, and we also want to reduce stigma and discrimination. So stigma, it occurs at 3 levels, social, institutional, and personal levels. And according to the 2014 Zimbabwe Multiple Indicator Cluster Survey, the following are the percentages of accepting attitudes. 43% among women, and 43% as well among men, and so forth. This is our vision under the Zimbabwe National Strategic Plan. We carried out what we call a stigma index in Zimbabwe, just to check the level of stigma within the society. And about 1,900 respondents participated in the research. And that is the breakdown that you see there of all the people who were actually interviewed. I think it cut across a whole spectrum of age groups and so forth. In terms of provinces, Zimbabwe has 10 provinces, and Harare province, which is the largest province, had about 13% of the respondents, followed by Bulawayo, which had 10%, and the other provinces had respondents varying between 8% and 10%. And 90% of the respondents were members of support groups, and that is the breakdown that you see down there. The 2015 stigma index study showed that 65% of people living with HIV experienced one or more forms of HIV-related stigma and discrimination. 31% were verbally insulted, 21% were excluded from social gatherings, and 19% was physically harassed. About 15% suffered from discrimination by partners, 12% psychological pressure, and so forth and so forth. a few people living with HIV, they reported being denied health services, about 2%. But none of the males were denied family planning services due to HIV-related stigma. 63% of the respondents said they disclosed their HIV status to adult family members. 74% disclosed their HIV status to their children. And lower percentages of respondents disclosed their status to their co-workers and so forth. And the data suggests that people living with HIV were willing to disclose their status to family, friends, and neighbors rather than individuals who were not close to them. In terms of recommendations after this particular study, it was felt that there should be increased initiatives to reduce HIV-related stigma within family settings and community settings, initiatives to reduce HIV-related stigma at the workplace, and health service providers are to be commended for ensuring that stigma and discrimination is quite low within the health sector. And there's also need to encourage efforts at reduction of stigma and discrimination within the religious sector. And also recommendations were that concerted efforts should be made at the education of the general community regarding HIV-related stigma. I'll just rattle through various programs within the country that are designed to reduce stigma. This one has already been presented by Dr. Apollo, the issue of scaling up of HIV counseling and testing. Because we believe once the people know their status, they are most likely not to stigmatize others. There are also behavior change programs that are taking place in Zimbabwe. There are behavior change facilitators who travel from door to door, creating demand for services. And within the program, there's a dedicated topic on stigma and discrimination, where household members discuss stigma and its implications to service delivery. Then there are also in and out of school programs targeting youth, teachers, lecturers, and sister-to-sister mentoring clubs, empowering vulnerable girls. I think you saw that the prevalence among girls is much higher than among boys of the same age group. Then there are also workplace programs, strengthening peer education and formation of support groups at workplace. Religious institutions are also actively involved in stigma reduction. And then we regularly carry out media workshops within the country, whereby we invite the journalists and the editors to sensitize them on barriers to access and services, including stigma and discrimination. There are community dialogues facilitated by Ministry of Health and Child Care, National AIDS Council, networks of people living with HIV, even the AIDS Project itself has also launched a big stigma reduction program in the Victoria Falls area. We work with positive speakers. We're talking about people who have disclosed their HIV status to families and communities. And we are also strengthening support groups and networks of people living with HIV within communities and at tertiary institutions like universities. And then we also involve the people living with HIV who go out to opportunistic infection clinics, talk to the clients, find out what the bottlenecks are, and also issues of institutional stigma. Then we also support self-stigma programs. And there are also beauty contests among people living with HIV, so that the communities don't see any difference between people who are living with HIV and those who are not. We also work with various key populations to make sure that double stigma is also reduced. And then this is a big one. We have regular engagements with the legislators, the advocacy meetings, whereby we meet members of parliament, senators to influence policy changes on restrictive policies. As a result, our parliamentarians went for public HIV testing a few years ago, and some were also circumcised publicly. So this has also helped to reduce stigma and discrimination. So these are some of the various issues that are taking place within the country to make sure we fight that last zero, we achieve that last zero of zero stigma and discrimination within the society. Otherwise, with those few words, I would like to thank you.
Dr. Mangure was highlighting the aspect of stigma, where as a country we are still dealing with various means and ways of addressing stigma at various levels, right from the very young to the policy makers. I think we have done some good amount of work. A lot of innovations have been put in place. I think we still need to have more innovations so that we reach our goal of zero stigma and discrimination. Moving on now, we go on to Alexio Mangiro. Is going to present to us on partnerships that help to roll out programming.
Thank you very much. I see some familiar faces in the crowd, but also it's great to speak after distinguished colleagues from our National AIDS Council and the ministry back in Zimbabwe. So I think when I was asked to speak at this event and talk about partnerships that help in rolling out programs that affect the community, I think the context behind this is exactly what Dr. Apollo and the ministry has put through, that gaps still exist, and that within Zimbabwe, across the board, partnerships are possible to be able to fill those gaps. So for other organizations out there that would like to come and fill these gaps and do some work in Zimbabwe, we are there, we are doing it, and it is possible. And at this time, as AIDS Project actually scales up some of the activities, maybe there are some important learnings from sort of the engagement framework that exists and all the support that we get from the National AIDS Council and colleagues in the ministry at all levels in helping implement programs that affect communities positively. So I think in terms of the mandate for health, the Ministry of Health has they have a number of priorities that they have to deal with: curative services, prevention. They have to balance out the issue of equity. They need to promote health. Non-communicable diseases are coming up. HIV continues to be a problem. But I think across all of this, the Ministry of Health is they're really focused on making sure that everyone is accessing health and that there is equity of access within that. So there are a lot of priorities. HIV is a big one, but you can see tuberculosis, malaria, sexual health, and so on. And they have to deal with all of that. And as organizations, as we come in as well, we may be focused on different areas, but the ministry has to focus on everything. Our focus in Zimbabwe is around HIV, malaria, and TB as the Clinton Health Access Initiative. So in terms of the ministry's mission, again, when they're crafting their mission, there are a lot of guiding frameworks within the region, globally, and all of those different international strategies to which they have to make a balancing act and create those priorities. But I think in working on partnership and in trying to create programs that can actually positively impact communities, it is important to take that guidance from the ministry, as at the end of the day, they are the custodian of the programs. And when all of us are not there, they will continue to exist and should be able to provide services to their citizens. So that's what guides our work. In terms of the engagement, there are several platforms, I think, at the national level to which partners like ourselves can be able to engage with the ministry, to engage with their priorities and be able to also contribute to this mission that they are driving. There are different technical working groups, different steering committees, different partnership forums to which partners we are welcome to make our contribution to how health delivery is going on in Zimbabwe and HIV in particular. But also going to every level. I speak after the CEO of the National AIDS Council, who at every level in the country, from national level, provincial, district, right up to the community level, they have structures to which us as partners we're able to work with to be able to have an impact on the communities. But again, in working with communities, the issues of stigma, capturing a lot of the feedback in the communities, capturing a lot of the experiences that we have implementing in the communities, and be able to have the feedback loop to be able to inform policy again. So we view it as a cycle in creating a framework of partnerships that allow us to roll out successful programs. There are a number of factors that help to be successful, which is all partnerships being centered around the ministry's priorities as opposed to each different partner's mission. That helps in creating a shared mission and purpose. Issue of transparent engagement, making sure that the government has buy-in in everything that you do as a partner, and that they are leading and they are coordinating. Those are some of the key things in creating successful partnerships that we can share with others. And then I think the community is very central to this, because for all of the programs, for all of the strategies, it boils down to the community. Right from the start of the cycle, we view this as a cycle in terms of the needs, identification of the needs. The community needs to be involved. Some of the research and the data that's been presented, that informs the planning, then should inform the policy implementation and how we view impact, and then have a full cycle again to redefine the needs and inform programs around these partnerships. So what we have also seen in terms of what the successful partnerships are that result in impact is that given all of the different groups that are trying to work towards healthcare, towards driving HIV programs, it could be private sector, it could be faith-based organizations, it could be organizations like CHIDE or AIDS Project, and we are all coming at it at a different angle, but the filter and point of convergency is the Ministry of Health, and that's the only way that we can be able to run successful programs that can impact the community. So that's also something that we have found to work in creating programs that can have an impact on communities. So I guess to conclude, I think the issue of government leadership is very important, and we have them represented here, and we need to rally around their priorities. The issue of sustaining impact, as different organizations we can come and work, but the government and its structures will always remain, and we need to work to capacitate them. The issue of identification of complementary skills is also important around this, in that not one organization brings all of the skill sets that are required to solve all these multifaceted programs. So the more we appreciate each other and warm up to each other and appreciate the different skills that each of us bring, then we have a better chance at going after some of these big goals, including some of the 1990 work, in addition to other country goals as well. The issue of involvement of the community as well. I think within the HIV space, the issue of there is nothing for us without us. The community has to be at the center of this. And with that, I thank you.
And it's my pleasure to introduce our next speaker. Our next speaker is Ms. Jane Bate. She is Strategic Interventions Advisor for UNAIDS in Zimbabwe. And Jane, I must let you know that your boss, Michael Bartos, Country Director, is watching you. Everybody from Zimbabwe is now receiving our connection.
I was asked to discuss in the context of the three presentations which have been made by my colleagues from the National AIDS Council, Ministry of Health and CHI, focusing on partnerships and how UNAIDS or the UN is supporting partnerships in Zimbabwe, but also looking at achieving the MDGs, especially MDG 6, and fast-tracking the 90s as we move forward. I would like to thank the World Health Clinicians team, especially Gary and Stephen, for having us here, and also Beat AIDS Project. In terms of partnerships, I think as we are here, this is a clear demonstration that partnerships in Zimbabwe, this is how we move with government, civil society, young people, and development partners. So the representation here today shows clearly that. Globally, as we all know, that the MDG 6 has been achieved and exceeded. And this is the first time in the United Nations for a target to be achieved even before the deadline. So as we congratulate ourselves, we also have to reflect and see where do we go from here. Zimbabwe is one of the countries which is specifically mentioned in the Global AIDS report for having halted or reversed the epidemic, but also one of the countries which has done much to have treatment, especially on the target of having universal access to ARVs. We all know that in 2000, when the MDGs were set, that was a time when many countries, including Zimbabwe, were very desperate. There was a raging epidemic with high morbidity, maternal and child mortality, and HIV was affecting other sectors. At that time, that was a death sentence. To have HIV, it was like that was the end of you, because we did not have treatment by then. But now, as we know that globally we have been able to put 15 million people on treatment, we also know that Zimbabwe is one of the countries which has been mentioned specifically for reversing the epidemic. It is mentioned among the 83 countries, including countries with high epidemics like India, Kenya, Mozambique, and South Africa. In terms of life expectancy, Zimbabwe had one of the life expectancies in the 80s, but at the time of setting the MDGs, the life expectancy in Zimbabwe had fallen to 44 years of age. This was because of many people dying due to HIV. And by now, by 2013, the life expectancy has risen again to 60 years of age. So that is a huge leap from where we were in 2000. As Dr. Apollo has already mentioned, in terms of treatment, I think we have almost 700,000 people on treatment, almost giving us 62% of those eligible under the existing guidelines. PMTCT coverage of almost 80%. That is a clear demonstration that moving the response in Zimbabwe within the partnerships of government, development partners, and civil society, we've been able to achieve that. Both Dr. Magure and Dr. Apollo mentioned the issue of investments. And as we all know that there's a lot of money which has gone to HIV globally, almost 22 billion mobilized a year. But Zimbabwe is one of the countries in the region which is a best practice, especially for mobilizing resources domestically. And with the AIDS levy, this has been shown that Zimbabwe has taken on shared responsibility to ensure that we not only rely on external resources, but we also mobilize resources locally. So, having reached there with some of the few things I've mentioned, how do we move forward? How do we fast track the 1990s? And how do we achieve the SDGs post-2015? The number of transformations we have to do or to look at are so many. We have like 15 transformations which are needed in the next 5 years to achieve the 90s by 2020 and by 2030. I will not mention all the 15, but I just want to point out a few key ones, like 5 of them, which also my colleagues have alluded to. Investments have to continue to be mobilized. This calls for increased shared responsibility and increasing resources to be mobilized domestically and also globally. As the world is mobilizing resources, we have to focus investments more in sub-Saharan Africa. The second key priority we have to focus on is targeting. Zimbabwe has just concluded the hotspot mapping, which shows where we have the populations and geographical settings which need more investments in terms of prioritizing and focusing resources. We have to change the way we do business and focus on the hotspots so as to be able to achieve the targets by 2020. Medicines, Dr. Apollo has already alluded to that, and all the barriers to accessing treatment and scaling up pediatric treatment is going to be very key. Then the issue of monitoring treatment, viral load scaling up, and scaling up of innovative diagnostics and viral load tests to ensure suppression as a contribution to achieving the 90 on viral suppression. Then the issue of young people. I think this is the time when we have to really invest a lot of resources and our energies in young people, ensuring, especially young girls, and ensuring social protection. And we have also to rethink and revitalize prevention. And this is the time, I think, when we have to reflect where we came from before we even had treatment. Zimbabwe is one of the countries which reversed the epidemic due to partnerships and social networkings and mobilizing communities for prevention. And I think we have to invest more in prevention because the sustainability of having people on treatment is going to be huge in the coming years. The last one would be integration, and as my colleagues have alluded to, but also integrating sexual and reproductive health rights, maternal and child health, and increased investments and engagement of communities and people living with HIV. So my discussion, I just wanted to say that whereas we have achieved, and as we celebrate that the MDG 6 has been achieved, the journey for us has to continue, and partnerships are going to still be key in terms of achieving the 1990s. Thank you very much.
Next, I've got the honor to introduce to you an incredible young man. His name is Mr. Edward Guebo. Edward is the past president of Interact, the Rotary Club organization for youth, but he is much more than that. Edward is a brilliant young man. E in Beat AIDS is for education, and education is a major priority in Zimbabwe, having the highest literacy rate on the continent at approximately 91%. And of course, education is a priority for Beat AIDS Project, with the E being bringing education advocacy and treatment for AIDS to Zimbabwe. Edward is going to be talking to you about being the first recipient of Beat AIDS Project Zimbabwe's Guardian Angel program, tuition assistance, and he'll discuss personal experiences as an orphan living with HIV, combating stigma, and how tuition assistance has helped him to complete his studies and to look forward to a professional future of his choosing. Our motto at Beat AIDS Project Zimbabwe is saving the next generation, and Edward is the next generation of Zimbabweans. Edward?
Thank you. According to the National AIDS Council of Zimbabwe, 1,400,000 people are living with HIV. In that figure, approximately 15% is made up of young people from the ages of 0 to 19 years. That amounts to approximately 210,000 young people. Ladies and gentlemen, despite these numbers, I would like to believe that 90% of the population is affected by the HIV virus. This belief would make us all HIV positive and negative This belief would make us all HIV positive and negative and help us appear to be on the same level. But the reality is No matter what numbers or figures we use, we are not. Living with HIV has many bittersweet moments. First of all, there is the adverse reaction caused by the medication. Then, the greatest of all challenges is the stigma we face. We have our peers passing negative comments and part of the community shunning us because of our status. Worst of all, our relatives discriminate us instead of being compassionate and understanding. I have relatives who treat me differently from all my cousins and siblings. I have peers and people from the community making me feel out of place. This happens to every voiceless, defenseless child and young person who is living with the HIV virus. But there is one thing that helps me understand why HIV stigma still exists. And that is because it is perceived to be attached to risky behavior and negligence of one's health. However, what everyone should know is that it is neither the fault nor the choice of any child born with and living with HIV. Stigma forces young people living with HIV to believe that everything they touch literally turns into ashes. Ladies and gentlemen, this has a great domino effect. Just a single comment or act of disgust makes us lose concentration in school. These actions also affect other things that really matter to us, like being of good use in the society and having a bright future of our own. Children living with HIV and those who are directly affected by the virus find it hard to share their experiences of the disease to aid in awareness and educational purposes. This then slows the process of ending HIV, the fight against HIV stigma. But thanks to organizations like AIDS Project Zimbabwe, HIV Equal, the Guardian Angel Program, Rose of Charity, and all concerned stakeholders, I am inspired to stand here and advocate for all those children who silently cry out to be helped. These organizations make everyone realize the importance of breaking the silence in their very own unique ways. They help orphaned and vulnerable children acquire school necessities, get people tested, and publish stories concerning people living with HIV. These stories help to share the experiences of individuals who have overcome stigma and who have learned to live with HIV by managing their viral load and go about their normal lives. Ladies and gentlemen, fellow delegates, let us stand against HIV stigma. A legal effort goes a very long way. Let us all unite in saving the next generations. Together we can. Thank you.
Thank you very much, Dr. Sandy. Appreciate it, and thank you for filling in for Dr. Mugarungi. And I'd like to thank Dr. Apollo today for also a brilliant presentation with Dr. Muguri, Lexio Manguero, and of course Edward. That was a wonderful presentation. So in closing, I'd like to tell you a little bit about AIDS Project Zimbabwe today. Just for a little background before we get started, AIDS Project Zimbabwe is an NGO. It's an initiative of our U.S. nonprofit World Health Clinicians. World Health Clinicians was founded by our Executive Director and CEO, Mr. Scott Gretz. And AIDS Project Zimbabwe was founded by Dr. Paula Greiger, as well as Scott Gretz. Our origins go back to the year 2000 when we first came to the African continent to see the International AIDS Society meeting in Durban at that point and visited Victoria Falls. In 2009 we came back to visit Victoria Falls and we met with Cryface Lusinga, his beautiful wife Tsitselo, and my godson teacher owner Gary Lusinga, who inspired us to set up AIDS Project Zimbabwe in Victoria Falls, and the rest is history that I'm about to tell you about today. So first of all, World Health Clinicians' mission is to prevent the spread of HIV and AIDS and sexually transmitted infections, as well as to reduce the associated morbidity and mortality rates in the developed as well as the developing worlds through education, patient advocacy, assistance, and education. As I told you, Scott and I have founded World Health Clinicians going back to March of 2010, and we were granted our US 501c3 tax exemption and nonprofit status by our Internal Revenue Service in September of that year. World Health Clinicians has several different initiatives, of which is our local medical clinic in Norwalk, Connecticut, the Circle Care Center, our 340B nonprofit pharmacy located on site, the Circle Care Center Pharmacy, as well as an incredible HIV anti-stigma campaign called HIV Equal, which I'll touch on in a second, and of course, Beat AIDS Project Zimbabwe. I'm sorry, let me go the other way. The vision of Beat AIDS Project Zimbabwe, as you can see, is to work in collaboration and partnership with the Ministry of Health and Child Care in achieving those three main goals. Zero new HIV infections, zero deaths with zero new AIDS-related infections, zero HIV/AIDS related discrimination. And we're doing this certainly with zero new HIV infections by our goal of saving the next generation through prevention of mother-to-child transmission, early infant detection, which I'll touch on, as well as diagnosis and treatment of children and adolescents. The zero new AIDS-related infections is working with the Ministry of Health, providing opportunistic infection prophylaxis and getting them tested for HIV, as well as offering all of these preventions. And lastly, we'll touch on fighting HIV discrimination and stigma in Zimbabwe through our very, very unique program called HIV Equal, and an incredible initiative by Tyler Curry, our Beat AIDS Project Zimbabwe magazine. And we'll go through just a couple of these before we finish today. So first, the Guardian Angel program. Edward mentioned to you that Beat AIDS Project Zimbabwe has provided assistance to youth to try to get them back into school. The reason for this is because UNICEF funding had ended for approximately 1 million orphans and vulnerable children in January of 2014. And as I mentioned to you from the podium before, education is a BAPZ priority, and it's a major Ministry of Health and Child Care and Zimbabwe priority. The Guardian Angel program mission is to provide tuition, books, school supplies, and uniforms to up to 5,000 OVC during the next 5 years through January of 2020. Currently, to date, we just in the last quarter of 2014, we identified with the Department of Social Welfare 305 OVC in the Victoria Falls municipality, as well as in the rural villages, and we are providing care to over 59 rural villages outside of the municipality of Victoria Falls at this time, in 12 rural health clinics and 6 non-service villages out there. But we determined these children to be our recipients in December of 2014. We also created this amazing community development project called the OVC monument, called the Wall of Hope. We actually brought on one day about 1,500 bricks, painted them all white, brought over 3 days about 150 OVC in from the rural communities as well as the municipality, and had them paint anything that meant hope to them. So as you enter our clinic, which I'll show you very shortly, you'll see this beautiful, beautiful touching wall of hope painted by and created by all of the orphans and vulnerable children who we are reaching out to. As I mentioned to you, our senior editor, Tyler Curry, along with our associate senior editor, Stephen Lucen, who wears many hats. And Stephen, we have to thank for the presentations today and this entire seminar. Stephen's World Health Clinicians, Head of Public Relations and Communications, so thank you for this, Stephen. And Stephen helped put together this entire Beat AIDS Project magazine. You'll see in the center of this photo is Dr. Owen Mugarungi, who couldn't be with us today, but Owen's been a very big supporter of, obviously, education. Owen, did you show up? Yes, good morning, Owen. How are you? Good morning. How are you, sir? Great. Nice to have you here in Vancouver. We're also working, as I mentioned to you, in 12 rural health clinics. Kanyambizi is one of these rural health centers. You can see the plaque that was put up here by former Minister of Health, the Honorable Dr. Timothy Stamps, in 1991. And we actually visited Kanyambizi in 1st December 2013 when we hosted our Beat AIDS Project Zimbabwe HIV Equal event. And then we returned in June of 2014. As you can see here, you'll see everybody holding up their Beat AIDS Project Zimbabwe HIV Equal photos, which I'll tell you a little about the campaign in a moment. But we returned also in April 2015 to see nature taking devastation on this rural health clinic. So you can see on the left there, this is the men's ward essentially there with a roof that had been blown off. You'll see over here in the female ward over here, maternity ward, the bats were taking up in the ceiling and the ceiling had to be taken down. You'll see the devastation basically over time. And what we've done with the Ministry of Health and Child Care is World Health Clinicians through Beat AIDS Project Zimbabwe awarded $40,000 to help renovate this clinic. I actually just got pictures yesterday. The renovations are going well, and we hope to have this done in the next several months. So that's one of the projects of what Beat AIDS Project does. The HIV Equal campaign actually is an incredible campaign that we launched here in the United States to fight HIV stigma and to try to get young MSM tested for HIV again. So we've spread throughout the United States. Over 2014, for about 14 months of work, we about 38% of people who came to our HIV Equal testing and photo events actually had never been tested before. Our mission basically is to end HIV and HIV testing stigma by creating this international and now national and now international multimedia educational campaign to promote HIV testing through the creation of a social art media movement using photographs that reignite the dialogue about HIV and AIDS, which then allows us to link newly diagnosed HIV positive individuals to medical care and to ultimately reduce HIV transmission and new HIV infection rates. This campaign was created by our brilliant creative designer, Thomas Evans, back in Connecticut, along with myself, and the campaign has been very successful. And we said, why not take this campaign to Zimbabwe and see what we can do to help reduce HIV stigma there and get people tested. So obviously we still deal with HIV stigma, specifically affecting men throughout the country. I think Dr. Mugarungi told me nationwide approximately 11.8% of men have been tested for HIV. Well, we decided to take on this mission, trying to get to men, healthcare workers, as well as the vulnerable populations that are mentioned. And the mission of Zimbabwe HIV Equal is the same as the US mission. To date, we've had 7 events over 14 months. 2 of them were in Victoria Falls Municipality over a 3-day period, which I'll show you a short video on, and 5 of the events were in rural villages mentioned up here. In those 7 events, we tested 1,262 people, and as Dr. Mugarungi said, the success we had was that we attracted 41% males overall to get tested at our events. And you can see we're now ramping up for children and adolescents also, and we have found an incidence in Western Zimbabwe of approximately 18% of the people we have tested being HIV positive, and this is consistent with the Ministry of Health and Child Care statistics also. We are also in one of the highest prevalence areas of Zimbabwe where this is really needed to be done. So here are some of our HIV Equal photos. Dr. Mugarungi, you can recognize yourself there on the left there. Every photo here. Dr. Maguri, you can see yourself on the right there. So we have the leaders of Zimbabwe, Dr. Mugarungi and Dr. Maguri, who posed for our photos. You can see every photo says everybody has an HIV status. We are all HIV equal. And down in the lower right or lower left, everybody chooses a one-word status that describes himself in a positive light. Dr. Mugarungi chose to use integrity, and yes, he is full of integrity and everything else you can possibly mention. As a leader of the director of AIDS and TB for the Ministry of Health and Child Care since 1999, one of the great men we have met here in Zimbabwe and are proud to work with. And Dr. Maguri, I think you chose your status to be generous, and indeed, as the CEO of National AIDS Council, he is generous and much, much more than that. So what I'd like to close with is you saw the beginnings of our specialty clinic there, and this is like the gem of what we wanted to give as a gift to Zimbabwe. And it's a free BAPZ HIV specialty clinic located in the high-density Mikasana Township in Victoria Falls. Our mission obviously is to help the Ministry of Health and their partners filling a lot of the capacity gaps and some of the unmet needs, such as in Matabeleland North and surrounding areas, as maybe we will get south of Bulawayo. We have offered them a beautiful, beautiful clinic, which I'm about to show you in a closing video, which has a full-service laboratory. We have the only Roche molecular TACMan 96 that will be able to do adult viral loads, along with the Ministry of Health and Child Care viral load rollout program. And this is the only viral load analyzer west of Harare, which is approximately 14 hours away from us. We also have a gene expert there for diagnosing TB and MDR-TB, as well as early infant detection analyzers that will help us diagnose children after birth within 50 minutes to 60 minutes after birth. Currently it's 6 to 9 months at that point, and it's a 30% mortality in the first year for children. So all this specialty care and treatment into this referral clinic. We're doing comorbidity surveillance and helping the Ministry of Health learn a little about renal and liver toxicities, and we will be bringing HIV specialists. So all of those in the United States and Europe who may be watching this presentation, you can contact us for sure, and we'll be working programs to bring specialists over there. In our second to last phase, we'll be developing a second addition to this clinic, which will offer an OVC drop-in center, an adolescent community center, as well as physical therapy and a fitness center, additional comorbidity surveillance, and procedure rooms that will help us reduce cervical cancer with high-resolution colposcopy and anoscopy. And I'd like to also do some work with the permission of the Ministry of Health and Child Care and Dr. Masuka to help people with facial lipoatrophy from the years of using stavudine during those days, a restoration of facial fat loss. So, in closing, I'd like to tell you that dreams do come true. This has been a 15-year dream of Dr. Greigers and myself, and could not have been doing this without our CEO, Scott Gretz, and all of our Beat AIDS Project team, everybody at World Health Clinicians. And I really do need to acknowledge all the people that have helped us make this dream come true. From everybody at the Zimbabwean Ministry of Health and Child Care. I'd also like to thank former permanent representative of the United Nations from Zimbabwe, Ambassador Chitsaka Chipaziwa, who back in 2009 introduced us to Dr. Maguri and introduced us to then Minister of Health, Dr. Henry Madzarera, and made this all happen. Dr. Greiger made the first trip to Zimbabwe and met Dr. Apollo, and she was very instrumental in helping us do this. And of course, we cannot do this without the help and assistance and guidance of our Provincial Medical Director of Montebello Land North, Dr. Nyasha Masuka. Thank you very much. Dr. Mugarunga, your support has been, incredible, and I really appreciate this. We have a great, great future together. And as an HIV specialist here in the United States since 1987, I hope we can offer you more of state-of-the-art that we've currently been offering to you, and we'll spread out around the nation with you, especially with HIV Equal and our other campaigns. So thank you to Dr. Maguri from the National AIDS Council. It's been an honor and privilege to work with you and partner with you in fighting HIV and AIDS in Zimbabwe. And most importantly, Beat AIDS Project would like to acknowledge all the Zimbabwean people living with HIV and AIDS and those affected by HIV and AIDS, along with all those who have given their lives leading to all the milestones achieved in combating HIV/AIDS in Zimbabwe. And before we go, if we can just have one moment of silence for all those people who have lost their lives to HIV and AIDS here in the United States, around the world, and in Zimbabwe. Just one moment of silence, please. It shows you now how everybody around the world can partner together, along with CHI, UNAIDS. We partner with Population Services International, PSI, Zimbabwe National Network of People Positive, Soft AIDS, Beat AIDS Project Zimbabwe. Thank you, everybody, for working together to help the people of Zimbabwe, and thank you all for coming this morning. Let's all go off to the plenaries. Thank you.